Respect colleagues, in partnership with the Société Francophone de Nephrologie, Dialyse et Transplantation, the Junge Deutsche Gesellschaft für Nephrologie, the Deutsche Gesellschaft für Nephrologie, and the Österreichische Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Paolo Mulatero in Turin, Italy, and Professor Maurice Brown in London, England, UK, to discuss the novel Endocrine Society Guidelines for Primary Aldosteronism, which shall lead our clinical practice in 2026, and to learn about potential options for even more precise approaches for diagnosing and treating primary aldosteronism in the hopefully not too far future. Dear Paolo, dear Maurice, it's a real unique privilege to have two global leaders in hypertension research back at home after hosting you for a first time in 2023 and 2024, respectively.
Dr. Maurice Brown is Professor of Endocrine Hypertension at Queen Mary University of London and the William Harvey Heart Centre, London, UK. He is past president of the British Hypertension Society and conducted landmark studies on antihypertensive treatment, including Pathway 1, 2, and 3, Time, and Accelerate. He's conducting seminal studies on novel approaches for diagnosing and treating primary hyperaldosteronism. Dr. Paolo Mulatero is Professor of Internal Medicine and Head of the Hypertension Unit, Department of Medical Science at the University of Turin, Italy. His main research interests are the genetics and pathophysiology of primary and secondary hypertension, focusing upon the pathophysiology, clinical and molecular genetics of primary aldosteronism. He's author of the 2025 Endocrine Society Clinical Practice Guidelines on primary aldosteronism.
So first of all, I would like to thank Professor Hein and all the team for inviting me to discuss the new guidelines this afternoon, also with Professor Maurice Brown. And so we go immediately to the presentation. Up to July 2025, we were with the old guidelines, always in this condition. There were patients to be screened depending on the risk and the prevalence of primary aldo in this specific condition. Patients undergo to screening test that, if positive, required a confirmatory test. And this confirmatory test give the diagnosis of primary aldo, and then we should do the subtype diagnosis to define the therapy, either surgery for unilateral condition or medical treatment for bilateral condition. As you mentioned, in July 25, it has been published the new Endocrine Society Guideline, and these guidelines were somehow different from the older version. First of all, because it was not presented in the usual format, but in the PICO format. So we were obliged to identify 10 questions in which we should define the population of investigation, the intervention, the comparator between one condition and the other, and the outcome to define the answer to the question. And we also had to take into account several points, like the importance of the suggestion, the evidence, the benefit and harm, the certainty of evidence, the feasibility, the resources required, the acceptability, equity, and so on and on. Let's go to the first recommendation, which that is a little bit different from all the other. That is, all individuals with hypertension should be screened for primary aldo. Before, we had patients at higher risk, like hypokalemia, resistant hypertension, and so on. So this time we decided to suggest the screening to all individuals with hypertension. This could seem a little bit too much, maybe just because of the passion of endocrinologists, but actually also the European Society of Cardiology suggested the same thing the year before. And also the American College of Cardiology, American Heart Association, despite a class of recommendation relatively low, they suggested to screen everybody or to consider the screening for everybody with blood pressure more than 140/90 for primary aldosteronism. When we suggest a universal screening for a condition, this point should be taken into account. That is the importance of the condition, the natural history, the difference in management, the availability of a specific treatment that result in difference in the outcomes. The test should be sufficiently accurate, cost-effective, acceptable for the individuals, and feasible to implement. And during my talk, I will try to justify this suggestion, underlining all these points. First of all, the prevalence. Several studies show that the prevalence is relatively high, even in the general hypertensive population, even higher in referral center, and definitely high in patients with resistant hypertension. Furthermore, we know from several years that aldosterone play detrimental effect in the cardiovascular system that are at least in part independent from the effect on blood pressure level, since it induce endothelial dysfunction, inflammation, stimulation of fibrosis, and all these conditions result in an increased rate of vascular damage, cardiac damage, and renal dysfunction. In fact, for example, in a patient with primary aldo, we have more left ventricular hypertrophy and systolic and diastolic dysfunction compared with patients with essential hypertension. We have more microalbuminuria and damage of the renal function. And this results in an increased rate of stroke, coronary artery disease, atrial fibrillation, and heart failure, even when patients with essential hypertension are matched for blood pressure level and other risk factors. And when patients with primary aldo are specifically treated, for example, with surgery in green, they display a lower rate of cardiovascular event. Patients treated with pharmacological therapy, with MRA, could display either a similar risk compared with patients with essential hypertension, where renin is no longer suppressed, and we will discuss later more in detail about this. But when renin is still suppressed, indicating that the patient is not sufficiently treated, so the dose of MRA is too low, or the patient is not taking the drug, we can see a higher rate of cardiovascular events. In the general population, the aldosterone-renin ratio, so not the diagnosis, thus the inappropriate aldosterone production compared with renin level is directly related to cardiac damage, and also to diastolic dysfunction. In the Framingham, so the American population and COMPASS study, Chinese population, you can see that in the context of low renin, the increase of aldosterone level was associated with an increased rate of cardiovascular events. And this was also true in the Canadian population. Interestingly, the risk increase when the aldosterone-renin ratio is higher than 2.5, which it has been the cutoff that was chosen by this guideline to consider positive the screening. And in the Swedish registry, patients with primary aldo display an increased mortality compared to control. Mainly, the death was determined by stroke. And in patients treated with adrenalectomy, the survival was longer. Patients with medical therapy display nonetheless a longer survival compared with patients with primary aldo not treated neither with surgery or medical treatment. And in patients treated with drugs, the longer survival was in patients treated with higher dose compared with lower dose. And finally, this is a new study in the Danish registry. We can see that again the level of aldosterone-renin ratio was directly related to a reduction of renal function and also to major cardiovascular events. Despite all this evidence, the screening rate for primary aldo was absolutely unacceptable. For example, here in USA, 0.5% of the patients were screened and only 1.6% of patients with resistant hypertension. In this Canadian study, only 1.6% of the patients with hypertension and spontaneous hypokalemia were screened for primary aldo. And even when the number of hypokalemia detected was more than 5 times, only 4.8% of the patients were screened. And even when the hypokalemia was particularly severe, so less than 3, only 3.9% of the patients were screened. These data are from Italy. You can see that all patients with hypertension were screened only in around 8% of the cases. And these are experts of hypertension, of the Italian Society of Hypertension, of the Society of Cardiology. And in patients of resistant hypertension that should be always screened, only around 72% of the cases were screened, and only 84% of the patients with spontaneous hypokalemia. But only 4% of hypokalemia associated with diuretics. So absolutely unacceptable. That's why we decided to give a strong recommendation to screen everybody. So before the physician need to find a reason for the screening. Now you have to find a reason not to screen a patient with hypertension for primary aldo. And so the screening requires measurement of aldosterone, renin, potassium, and the aldosterone-renin ratio should be calculated. The cutoff suggested is 2.5 for when aldosterone and renin are measured in chemiluminescence. A lower cutoff is suggested when aldosterone is measured in LC-MS. We also suggest that a minimum level of aldosterone should be required, that is 10 nanogram per dl, and a minimum level of renin, that is 8.2. This because, especially for aldosterone, is important because you can have a high aldosterone-renin ratio even when aldosterone is relatively low, and in some cases even lower than the cutoff for a suppression test. So this means probably the patient is taking high salt diet, or maybe he has a little syndrome, or is taking licorice and so on. So a minimum level of aldosterone is required, and also of renin. The cutoff derived from several studies from Italy and Germany. This is one of the studies in which the higher sensitivity for the screening test was obtained between 2 and 2.5. I know that some unit elsewhere use a lower cutoff, that is 1, for example, many German center, and this could be due to either the fact that they measure the aldosterone and renin with the ISIS method, or because they want to be absolutely 100% sensitive. You can see that 100% sensitivity it can be obtained at the level of 1. The problem is that it is suggesting a universal screening using such a low cutoff that would result in too many positive screening that cannot be handled by all different sanitary systems. Of course, we can be with some concern for false positive result, especially in patient taking beta blockers, or falsely negative result, especially in patient taking different type of diuretic, especially MRAs. So again, we had three possible management strategy. One very pragmatic, in which no medication is withdrawn. We know that with this we can lose a number of patients taking interfering drugs, but it's also true that a very florid phenotype would be nonetheless diagnosed. So this is to avoid that some physicians are too scared to change the background therapy, and they do not screen the patient. So patient with a very florid phenotype, even under interfering drug, could be still diagnosed. Then there's an intermediate strategy in which beta blockers and all type diuretics, especially MRA and amiloride, are withdrawn. And the ideal strategy in which all interfering drugs are stopped and only alpha blockers, non-dehydropiridine CCBs and moxonidine are allowed. Of course, we can still screen under interfering therapy and taking into account the theoretical effect of some drugs on renin level, aldosterone level, and therefore on the aldosterone-renin ratio. So what happens when we have a positive screening? We have to ask ourselves and to the patient if this patient could be candidate for surgery in case of unilateral disease. If the answer is no, so we should consider a therapy with an anti-aldosterone drug. At the moment of the guideline, mineralocorticoid receptor antagonist. If the patient is a candidate for surgery, but the phenotype is so mild that the probability of having a unilateral disease is absolutely negligible, again, we should consider therapy with MRA or anti-aldo therapy. Very mild phenotype is a patient with just mild hypertension, normocalemia, aldosterone is just above the cutoff, aldosterone-renin ratio level that is just above the cutoff again, and so on. Why we consider an option to give MRA even in patients without the classical diagnosis of primary aldo? Because in some study, and this meta-analysis described the result of all the study pulled together, MRA displayed similar efficacy of thiazide diuretic in reducing the blood pressure level in patients with low renin hypertension, so patient without the diagnosis of primary aldo, and they are even better than RAS blockers, either ACE inhibitor or ARBs, in reducing systolic blood pressure. Happen if the probability of unilateral disease is high because the aldosterone-renin ratio is very high, because there's hypokalemia, because the renin is not measurable because it's completely suppressed, aldo is very high. In that case, we know that the probability of unilateral disease is high, and this patient, we are sure they are primary aldo, so we can avoid the suppression test that were called confirmatory test in the old guideline. And therefore, suppression tests should be dedicated only to patients with an intermediate probability. And this test of suppression should be considered not to confirm or exclude the diagnosis of PA, but only to give the indication of performing CT scanning and adrenal vein sampling to identify patients with unilateral disease. Some author suggests just to consider the aldosterone ratio and that aldosterone suppression test should be completely abandoned. But we agree with them because when aldosterone ratio is very high, of course we have primary aldo. When it's very low, we can exclude primary aldo. But we have so many patients in this gray area with mildly increased aldosterone ratio, we cannot send all these patients to lateralizing procedure with AVS at the moment. So we need to perform another test to decide if the patient required subtype diagnosis or not. And also we know that there's a huge fluctuation of aldosterone level during the day and within days. And aldosterone level after post suppression test, they are much more solid indicator of organ damage compared to a single measurement of aldosterone in a random condition. Therefore, we suggested 3 possible suppression tests. One is used practically only US, is an oral sodium suppression test. In Europe, we prefer seated saline suppression and captopril challenge test. We also suggested 2 cutoff for the diagnosis. Of course, even in this case, we have a gray area. And also potassium level should be taken into account. And so, again, a very positive or a very negative result is informative. When we are in this area, we have to take it into account the general clinical picture and absolutely the potassium level. So what happens when the suppression test is negative? So we have a positive aldosterone ratio, intermediate probability of unilateral disease, and negative suppression testing. So we cannot consider this really primary aldo required subtype diagnosis. We could call that inappropriate aldosterone production, but this patient, for the reason that I described before, can still merit some therapy with an anti-aldosterone drug. We also have to consider that in some cases, this patient could have a very subclinical initial form of primary aldo. And in fact, in this study that we performed with our German colleague, during the follow-up, some of these cases became primary aldo, 16% of the cases in Torino and 24% in Munich. So we still need to follow up this patient because some patients can develop florid PA. I mentioned the fact that some authors are really now pushing against the performance of suppression testing, and especially the group of Boston and the group of Montreal. However, many of us believe that the reason they support, they are not, we cannot agree with this points because, for example, in this study published in Annal of Internal Medicine, in some cases they consider a response to MRA treatment as a proxy of PA diagnosis. We know that MRA are efficient in low-renin hypertension, so this cannot be considered an indication. Hypokalemia was not corrected before a saline suppression test, and this is well known to give a negative result that are falsely negative. Also, they perform at any hours the suppression test, and when it's not performing in the morning, early morning, the result at 2 p.m. cannot be acceptable. And so, taking together all these limitations, we could identify only 3 false positive out of 134 studies, so a minimal extra burden on AVS, taking into account all these limitations. In this other study, the author compared patient undergoing suppression test with saline load or captopril, and they took so many different cutoff just to say they are not consistent one to the other. However, if we consider a sensitive cutoff for the saline suppression test, the sensitivity for unilateral PA was 98%. Taking the suggested cutoff for a captopril test was 95% of sensitivity. So actually, this study, in our opinion, suggests that the suppression tests are very informative for unilateral PA. And we know that a negative suppression test cannot exclude definitively a mild bilateral PA. And that's why in our guideline, we suggest even in patients with a negative suppression test, we suggest to consider an anti-aldosterone therapy. So for patients with a positive suppression test and for those with high probability after the screening test, patients should undergo a subtype diagnosis comprising adrenal CT scanning and AVS to identify patients that benefit from surgery and patients that require medical therapy. Adrenal vein sampling can be performed in different protocols, and the guidelines don't go into detail to identify preference for one protocols over another. But we know that without AVS and relying only on CT scan, the probability of having a persistence of primary aldo is between 12% and 20%. Different cutoff are suggested. I will not go into detail, but we know that there is some hope to overtake the requirement of AVS. I guess Professor Brown will go into detail, so I will just mention the possibility of PET-CT with metomidate that have the limitation that require a cyclotron next to the radiology. There's some studies suggesting the possible use of the Pentixafor PET that display a very good specificity in some study, but relatively low sensitivity. And now the biggest hope is the AldoView strategy, just published in New England a few months ago. And this is a tracer that binds to aldosterone synthase, and the first results are very promising. Going to the medical therapy, it is suggested to prefer spironolactone over other MRAs, and also compared with amiloride. When blood pressure is not controlled with a certain dose of spironolactone, we should check renin levels. If renin level is no longer suppressed, that means the patient also has primary hypertension, and so we should increase or give another antihypertensive drug. If blood pressure is not controlled and the renin is still suppressed, we should first of all check compliance of the patient, and if the patient is supposed to be adherent to the therapy, we should increase the MRA. If the patient do not tolerate spironolactone, we should consider eplerenone at a dose that is the double in terms of milligram compared with spironolactone. So if the patient is well controlled with 50 milligram of spironolactone but display gynecomastia, we should give 100 milligram of eplerenone 50 twice per day. If eplerenone is not available, we should consider amiloride. Amiloride that should be given at a dose of 5 milligram every 12.5 milligram of spironolactone. We have new medical treatment. I guess Professor Moritz Brown will tell us about this, so I will not mention any of the new drugs. And there are also some other no pharmacological treatment that are coming into the clinical ground. And again, these were not discussed by the guidelines. With this, I finish my beginning of the presentation and thank you for your attention.
So thank you very much. Before we move on to the discussion, we would now like to hear the second presentation by Dr. Brown.
Well, thank you very much for asking me to take part in this session, and huge congratulations and thanks to Paolo. I'm always full of admiration for people who devote so many hours, days, weeks to guidelines. It's an almost thankless task. I did my stint many years ago with hypertension after proposing my ABCD rule, which then became part of the first nice British Hypertension Society guideline, but I haven't taken part in any subsequent guideline writing. My talk is a version of one I gave at the American Heart Association last November 2025 as part of a session arranged by the AHA editors entitled New Paradigms in Primary Aldosteronism. And the session, and certainly my own talk, was prompted by the rather nice coincidence of the guideline you've just been hearing about, the almost coincidental guideline that Paolo mentioned in hypertension, and the recent phase 3 trials of the aldosterone synthase inhibitors in resistance and uncontrolled hypertension. And I'll be touching on those later on in my talk. And then after that session, I was invited by Hypertension to write the narrative for the talk as a commentary for hypertension. And this is the somewhat tongue-in-cheek title that I've given my talk. So one of the coincidences is that the same year that aldosterone was discovered down the road from where I work in London by the husband-wife team Vitates, also saw the start of a long-running debate between two doyens of the British medical establishment at the time, 1952, Platt, who was president of the Royal College of Physicians, Pickering, who was professor of medicine at St Mary's and later Oxford. And they had diametrically opposite views on pathogenesis of hypertension, with Platt believing that it was due to a single gene and that the blood pressure distribution in the hypertensive population was quite separate from the rest of the population, whereas Pickering, correctly of course, predicted that hypertension would be polygenic, many genes contributing, and that there was a continuous distribution of blood pressure with hypertension as the extreme end. So today we may smile almost at the naivety of Platt, and yet before leaving this slide, it's interesting to note that in the context of primary aldosteronism, most of the cases, whether unilateral or bilateral, are due to not inherited but somatic mutations in one or other of two main genes, a calcium and potassium channel gene, that again I'll be mentioning later on. So this we all accept. And then we turn to primary aldosteronism, and all I've done here is change the x-axis of these graphs to aldosterone-renin ratio. And suddenly the rules seem to change a bit. The primary aldosteronism, on the one hand, much of what we talk about does respect the fact that there's a continuous distribution of the aldosterone-renin ratio, and yet we talk about the condition as though it were distinct. And when we come to what will be much of the theme of my talk, this 99% of missing patients that Paolo very eloquently described, the question is whether the 99% whom we don't diagnose are truly the same as the 1% whom we do diagnose, or whether, which I would submit to you is the more likely, given that opportunistic diagnosis tends to pick up the more severe version of a disease than systematic screening, that the 1% we already diagnosed are those at the extreme of the aldosterone-renin ratio, and the ones who are missing are missing in plain sight, as I put it in the commentary, largely within patients with resistant or what's now becoming called uncontrolled hypertension. And it's for these that we've coined this term primarily aldosteronism, in whom we treat them as being due to an excess of a hormone without worrying too much about making a hard and fast diagnosis. So now for some data, and 20 years or more ago, I undertook a study myself looking at how common the condition is. And I'm not presenting this as either the right or wrong answer, but more just to discuss some of the complexity and difficulty about drawing a line. If you plot the plasma aldosterone against the renin, in this case 846 randomly selected patients in primary care, there's actually 5 different general practices around Cambridge where I was working at the time, this is what the data looks like. And if primary aldosteronism didn't exist, what you would expect would be a sort of straight line correlation between renin on the x-axis as the main driver of our angiotensin of aldosterone on the y-axis. And yet there's clearly a group of people whose aldosterone is inappropriately high for the level of renin. And the problem is where you draw the line and say that there was a group who is pathological. And the extra measurements that we did in this study was a CT or occasionally an MRI scan in all the patients who had an aldosterone above 400 and an elevated aldosterone-renin ratio. And that was 78 patients. And in those days, it was 2005, we found only one definite adenoma. Now, the other thing which was very clear from this study was the profound effect of drug treatment. And red is the patients being treated with an ACE inhibitor, and blue, the patients being treated with a beta blocker. And it's obvious that the beta blocker is shifting the renin to the left, the ACE or ARB to the right, and that as a result, most of the patients in this group of inappropriately high aldosterone ratio was due solely to their beta blocker. And if what we did at the end of the study was to challenge with a month of spironolactone all the patients with an elevated aldosterone-renin ratio. And the y-axis here now becomes a fall in blood pressure after a month of such treatment against their baseline level of renin activity. In the blue patients, the ones treated with a beta blocker, the line is pretty shallow. In other words, a high aldosterone ratio on a beta blocker is not usually reflective of having an aldosterone-dependent hypertension. Whereas if I take away the beta blocker treated patients and only look at those treated with an ACE or an ARB, a relatively low renin, despite being on a drug which should be elevating your renin, turns out to be highly predictive of a good response to spironolactone. And I absolutely agree with Paolo's caution on saying this necessarily means you have primary aldosteronism, but at the least we can say that the patients who have a low renin will respond to spironolactone. And actually we do know from data that was published as part of the MATCH trial I'll be coming to, that a good response to spironolactone is highly predictive of a good response to taking away one adrenal. Now, it's often said that the stimulus to finding a much higher prevalence of primary aldosteronism than used to be thought was the recognition of the power of measuring aldosterone-renin ratio rather than aldosterone alone. But in preparing for my talk, I went back to some of the older literature and found this paper from 1981, where I think it was around 300 patients, the aldosterone-renin ratio was measured, and we look at the number of people with each level of the ARR. And the authors concluded that only 2.5% of patients had an ARR that was diagnostic of primary aldosteronism, and all proved to have APAs. Now, it's likely that where they've drawn their line might seem a bit high to us. But the date 1981, I realized, is interesting because it was about the same year, if not a year before, the advent of the ACE inhibitor class. And I remember a phenomenon which has largely disappeared from parlance or recognition called the ACE escape, where in the early days of use of this class, various authors, and Jan Staeson's a very respected clinical trialist, published data showing that initially, as you might expect, the level of aldosterone on the y-axis in orange falls with use of the ACE inhibitor, but over months of treatment, the aldosterone level escapes from inhibition, and in this particular study, there's even a suggestion of a rebound. And despite looking, I couldn't find any good data for what happens to the aldosterone over the month or so after you withdraw an ACE inhibitor. And I just worry a little that some of the larger prevalence studies for which the background treatment was withdrawn may have overestimated the true prevalence. Conversely, it may be that the ACE inhibitor truly is in some way contributing to a bit of an epidemic of primary aldosteronism. And we now know, for instance, that the adrenal is full of various other substrates of the ACE enzyme, such as substance P, which are good stimuli to the production of aldosterone. But suffice it to say, aldosterone escape may have now become a forgotten phenomenon, but it was sufficiently well recognized in the 1980s and 90s that it led to Bertram Pitt, one of the doyens in our field, to start his studies of mineralocorticoid receptor blockade in the treatment of heart failure. I've got two final slides on the biochemistry, and then we'll turn to the anatomy of primary aldosteronism. And one of my themes is that the missing patients are hiding in plain sight as resistant hypertension. So I want to show you some evidence for that. And I was the leader for a series of trials we called Pathway in the 2008-2015 was a period we did these on behalf of the British Hypertension Society. And because one of the trials, Pathway 1, was looking at previously untreated patients and another at resistant hypertensives, it gave us the opportunity of comparing the response to treatment and the spectrum of plasma renin in these two groups. If I look at Pathway 1, the previously untreated patients initially, and we have a plot of the fall in systolic blood pressure against plasma renin, with, as our ABCD rule predicted, the low renin patients responding better on diuretic, the high renin better on losartan. The median level of renin is just under 10 in milliunits per liter. So I should say the crossover point, at which point the patients are more likely to respond to the renin blocking drug, is just to the left of the median for the renin distribution. And this is in stark contrast to what we saw in the resistant hypertension population, which many of you will remember was a crossover trial of 3 different active drugs against placebo. But I've plotted the data in the same way here, the change in systolic blood pressure against the baseline plasma renin. Once again, the low plasma renin predicted those who had the best response to spironolactone, and really there wasn't a very good response to either of the other drugs, doxazosin or bisoprolol. But the key point is that the crossover here at the level of renin at which patients were at least as likely to respond as well to the renin blocking drug, in this case bisoprolol, as for diuretic, is at the extreme right-hand end of the renin distribution. So although biochemically the levels of renin appear a bit higher in the resistant hypertension group, that's simply because they're on 3 background drugs, a diuretic, calcium blocker, and a diuretic, each of which were increasing renin. Functionally, they're behaving as a very low renin group, responding much better to a diuretic type drug than to a drug that blocks renin. Now, we went on in a sub-study of Pathway 2 to measure plasma aldosterone as well as renin. And in the plot, like in my first data slide of aldosterone against renin, you can see that much more than in our general practice population, we almost exclusively, the low renin end of the spectrum in the male patients have an inappropriately high level of aldosterone. And some of these we followed up and indeed found discrete adenomas with somatic mutations. For the women, it's much less clear-cut, and that's interesting because, except for the KCNJ5 mutant tumors, which are commoner in women than men, most of the smaller ones that present with hypertension have quite a marked male predominance. So I'll show you a bit more evidence that resistant hypertension is not only a low renin, but probably a primary aldo group of patients. But if we looked at the various predictors of the fall in blood pressure, the renin data you've seen already, there's a slightly weaker correlation with a large fall in blood pressure being at the high end of the aldosterone spectrum, and marginally superior to renin alone as the aldosterone to renin ratio, with the best fall in blood pressure being in those with a high aldosterone renin ratio. And then finally, what we did was use a previously described index, SPARK, which is effectively an index of sodium potassium clearance, measuring sodium and potassium in both blood and urine. And these were the plots for the fall in blood pressure against SPARK for each of the drugs in the Pathway 2 study. And I've just pulled out the response to spironolactone, showing that the people who had the greatest response to spironolactone are those with the highest ratio of sodium to potassium in their urine against the ratio in blood. And 5.3 was the previously published threshold when these values were compared with aldosterone renin ratio, and gave us a figure of 38% of all patients with this rigorously diagnosed group of resistant hypertension having primary aldosteronism. Now, spironolactone response, as both Paolo and I have said, one can't be sure in individual patients or even a group whether it's truly working through an effect on aldosterone. But when we turn to the aldosterone synthase inhibitors, one can achieve that data. And this was the study that I led with the group, in this case, Syncal, with baxdrostat, a phase 2 study in resistant hypertension, showing that there was a dose-related increase in the fall in blood pressure. And in this case, you can see that dose-related increased fall in blood pressure is matched by a dose-related increase in the fall in aldosterone. And in a post-hoc analysis that wasn't in the published article, looking at the fall in blood pressure against the fall in aldosterone renin ratio, you can see there's a decent correlation. So this, in a way, was the first proof that the response to blocking the aldosterone axis in resistant hypertension isn't a non-specific diuretic effect. It's due to targeting aldosterone. So as I said, I would come to an end on talking about biochemistry, maybe summing up that it is a continuum, and it's very hard to draw a line and say convincingly this patient has primary aldo, this patient does not. Whereas it's interesting to remember that back in the 1950s, when Conn's syndrome was first discovered, it was based on finding a high level of aldosterone in the urine of the index case, but then in finding an anatomical tumor. And I'm sort of a mixture of bemused and amused that over the many years since then, not much has changed in routine practice over roughly the last 60 years. And that is embodied in the new guideline that we've been hearing about. Adrenal vein sampling, CT scan, laparoscopic surgery is still the centerpiece of the management that is recommended. And that's in contrast to, and despite really at least a decade and a half of almost spectacular advances in our understanding of the condition, particularly on the molecular science front. And this sort of pyramid that I draw is meant to represent 3 advances that both ex vivo and in vivo can, and I would argue should be, impacting on our everyday practice. One is the discovery of the somatic mutations, which started with this landmark paper of Rick Lifton's in Science, and then several others were found. And the interesting thing about their finding was that they showed there were 2 main different types of the APAs, and the importance of that I'll come to. The second was the advent of molecular imaging, and I'll be saying a bit about that. And the third, and very important, was the advent of the highly specific antisera, which for the first time allowed us to see the enzyme making aldosterone distinct from that making cortisol. And one of the early finds from those antisera was within what I sometimes call the classical Cons tumor, the one we now recognize to have the casein J5 mutation. Paradoxically, there's more expression of cortisol than there is of aldosterone, whereas in the smaller tumors that our molecular imaging bit by bit led us to, they're almost purely making aldosterone and very little of the enzyme making cortisol. And just before I forget, I should say that one of the clinically very important consequences of this mixed cortisol-aldosterone picture is that these tumors make a hybrid steroid that we can now measure as a pretty good predictor of the patients with the casein J5 mutant tumor. But this pyramid does not take us to the bottom of the pathology, because really the supreme success of these antibodies was the discovery of aldosterone producing, initially called clusters, now called micronodules, which are present in at least half the normal adult population, more like 75% of those with primary aldosteronism, and probably underlie much of bilateral, so-called bilateral idiopathic hyperplasia. And the newest of the molecular ligands, I don't think they can detect individual micronodules, but they do have a potential for delivering a signal where there's no anatomically visual abnormality on the scan. So that leads me nicely into the first of our prospective clinical trials, which had the primary objective of validating molecular imaging, metomidate PET-CT, against adrenal vein sampling. And before I show you the headline result, and taking up the very important point that Paolo mentioned, that carbon-11 has a half-life of 20 minutes and therefore is only useful in hospitals with an available cyclotron, in the second part of what we call the MINICH study, we validated an 18-fluoro analog of carbon-11 metomidate. And this shows a couple of patients, one with a large tumor, one with one of our smaller tumors, showing that we effectively get identical pictures with the two radio tracers, with the 18 fluoro having the advantage not only of a 2-hour half-life, but also very, very little liver background and probably therefore better accuracy on the right-hand side. And to sum up our comparison of the two radio tracers, out of 31 patients, 18 on metomidate, only one fewer on CETO, were scored as having high probability of unilateral disease and went to surgery. I thought this would be the point of my talk. I'd also pick up, again, Paolo's mention of the more recently published aldosterone synthase inhibitor used as a radiotracer. Aldoview is actually a molecule that Merck was developing as part of its ASI program. I spotted it in the medicinal chemistry paper as a fluorine-containing inhibitor, which had been tested in primates and therefore seemed ideal for converting to an 18-fluoro radiotracer, and brought this to colleagues at University College, and Eric Arstadt really led its development there, and the study that was published in New England at the end of last year. And these few pictures illustrate there's almost zero background in the rest of the adrenal in this case, and it is possible to detect really very small lesions with no anatomical background. But this hasn't yet been tested against clinical outcome, and there's much still to do before it could enter routine practice. So that brings me to the rigorous assessment of how accurate the molecular imaging is against adrenal vein sampling, and our prospective endpoint was looking at the PASO criteria for success after surgery in the roughly 2/3 of patients who were positive on either the molecular imaging or the adrenal vein sampling and went to surgery. And the bottom line is that whichever the PASO criteria you use, complete or partial, biochemical or clinical, the difference in accuracy as a point estimate, except for complete clinical success, favored the molecular imaging, and none of the lower bounds of the confidence intervals crossed our preset margin. In other words, we were able to declare non-inferiority for molecular imaging. So I would say, with reference to the guideline, that we in the imaging field were a little surprised that when the guideline in 2025 referred to imaging as research in progress, because we have been in progress since 2008, and paradoxically, there's now more rigorous evidence for the molecular imaging against outcomes than exists for adrenal vein sampling. And the molecular imaging is completely non-invasive. The V18 fluoro radiotracers can be used in any hospital that currently undertakes 18 FDG. In other words, most secondary centres that are undertaking cancer imaging could, in principle, undertake scanning now for primary aldosteronism. So I want to concentrate on the group of patients who achieve complete success, and maybe more importantly, those who fail to achieve complete success, which is the majority of patients. And the PASO view has been that the failure to achieve complete success in most patients going to surgery is due to things like coexistent essential hypertension, secondary vascular changes from primary aldosteronism. But we increasingly think that the recognition that much of primary aldosteronism that used to be called unilateral is actually asymmetric bilateral is the reason for failure to cure clinically after surgery. And this is a plot of the aldosterone-renin ratio after surgery in patients whose clinical success is shown on the x-axis. And if you think about it, if there were no relationship between the odds of biochemical success and clinical success, then we shouldn't see a higher aldosterone-renin ratio in those with partial or absent biochemical success, and yet they're clearly related. And when we took the people with partial success and did a confirmatory test, we can see that 2/3 of them failed to completely suppress, and indeed most of those, as you might expect, with absent success, failed to suppress. So the summary of this is we think that the main reason for not being completely cured by surgery is a failure to recognize contralateral disease. But one of the challenges to improved imaging is the ability to detect the contralateral lesion. And we recently, towards the beginning of last year in Annals, we published a 2-year follow-up, as was pre-planned for the MATCH study. In this case, mentioning the difference between blood pressure and plasma renin in those who had the surgical treatment and those who had medical treatment. And you can see that by 2 years out, there is actually no difference between them. And we think that puts quite a lot of emphasis on the importance of trying to do better to predict who truly benefits from surgery and in looking for alternative, less invasive options to surgery. So firstly, trying to predict, and this is where somatic genotyping and surrogates for that seem to come into their own. This is a count of a number of people with each of the somatic mutations that we found in the adrenals removed from the MAP study. And as I mentioned earlier on, by far and away the two commonest are the calcium and potassium channel mutations, but with a very striking ethnic variation, and Black patients very rarely have the casein J5 mutation. And that turned out to be relevant to a rather poor outcome after surgery in Black patients. Because when I replot this data only now for those who have achieved complete cure, blood pressure 135 over 85 or less off all treatment, you can see that the only genotype really that's left standing is the casein J5 genotype. And on a logistic regression analysis, it trumps all other variables like female gender and younger age, which also in a univariate analysis predict a good outcome. And the really good news is that we can predict the casein J5 genotype in advance by measurement of hybrid steroids, the steroid which is only produced if you have both the aldo and cortisol-producing enzymes in the same cell. And in the 24-hour urine samples, you can see there's almost blue water between all our casein J5 mutant tumor patients and those with the other mutations. So we're repeating this in our current prospective trial, and I think if that is replicated, we would be recommending that in future surgery is largely reserved for people with a high hybrid steroid level. So what about the alternatives? And I'm just going to say a word or two now about these and then wind up. Interventionally, we put a lot of effort into developing less invasive procedures, in particular ablation on the left-hand side, where we can approach the adrenal via the stomach in an almost non-invasive manner, scarless. The tumor is seen by an ultrasound probe in the stomach. And we've dubbed this targeted thermal therapy or triple T. And as these figures illustrate, the molecular imaging shows us where the endoscopist should be targeting. He sees this under ultrasound, using ultrasound in the stomach. The probe is really only 1 centimeter away. It can be manipulated, and over just 10 or 15 minutes, the whole of this tumor is ablated, and the patient comes back 3 months later, and we see disappearance of what has been ablated. So FABULAS, this paper last year, was a proof of concept trial of 28 people. We've just finished recruiting for the WAVE trial, and this is a head-to-head of patients, 66 having ablation, 44 having surgery. And to sum up, if using the MasterCard advert, we would say that for those predicted to have the casein J5 mutation, we would recommend surgery. And for everyone else, it's medical treatment, or if WAVE is successful, radiofrequency ablation. So to conclude, I want to come back to the aldosterone synthase inhibitors. And this is a very exciting year because baxdrostat is one of 2 or 3 of the second generation non-imidazole inhibitors. Paolo himself led research in primary aldosteronism of dexvadrostat, which used to be FAD286 and was predicted to be a very effective drug 20 years ago. And baxdrostat, as you saw, has been investigated both in resistant hypertension and this small study in primary aldosteronism, and if all goes well, I believe is set to receive its market authorization from the FDA during this year. But I'd like to finish with this small study, 15 patients in primary aldosteronism. And what we're looking at here is the 24-year aldosterone on the y-axis against treatment on the x-axis. And the study had 2 parts, 12 weeks with the primary endpoint at the end of 12 weeks, and there was dose titration, and then people remained on their dose they'd reached for up to another 60 weeks. And you can see that one of the messages from this is not only the rather large but completely open label fall in blood pressure that was seen, roughly 25 millimeters over part 1, but with a hint that that is not the peak response, and that by another 30 weeks later, the fall in blood pressure may be as large as 30 millimeters. But what also seems to take time is the possibility that these drugs are not just treating, but maybe even curing primary aldosteronism. And we were fortunate in a way to have 4 or 5 patients who withdrew early from the trial, but came back at the end of the study for repeat aldosterone measurements. So this is the same plot now, but only in the patients who withdrew, particularly highlighting in the dashed line the 3 patients who came back for later measurements of their aldosterone. And you can see that in all 3 cases, their aldosterone level remains completely suppressed. And my hypothesis, and we predicted this in a Nature review, is that this sustained suppression is due to an effect observed 20 years ago in the knockout models of aldosterone synthase in rats, or mice rather, that the disappearance of the enzyme leads to apoptosis of the aldosterone-producing cells. And we're about to start on a molecular imaging study where patients are being imaged at baseline and then 2 months after stopping after a minimum of 6 months treatment. So I sum up with a schema and very similar to some of the schemas that Paolo showed you, but really there is a complete spectrum And this is illustrated both in what we observe after the adrenal comes out using the antibodies to aldosterone synthase, where at the extreme there's a patient with a solitary tumor who will do very well by having that adrenal removed. But then there's all levels of macro, micro aldosterone synthase expression in the adrenal. And we can see the same with the in vivo molecular imaging between the patient who clearly just has one adrenal nodule on one side and those where we start to think that there's nodules on both sides. And so the implication is that we should be using our treatment, our interventional treatment, very selectively at the right hand of this axis, and medical treatment. And a point which maybe I didn't make firmly enough when I presented the data, rather than basing it on these very difficult to, and not based on prospective data, thresholds for aldosterone-renin ratio, and basing the medical treatment on what the hypertension community have used for decades, levels of entry into clinical trials will translate into long-term improvement. So I've shown you a number of studies, and I've got to give tribute to both senior colleagues and many talented junior colleagues who have taken part and led on these clinical trials. Thank you.
Thank you very much, Professor Brown, for this truly brilliant talk, bridging early findings of primary aldosteronism with recent data on imaging and new emerging therapies. I would now like to open the discussion by inviting Professor Mulatero to comment on Professor Brown's talk, especially regarding the mentioned new imaging techniques as AVS alternatives and why they were not included in the guidelines.
Okay, thank you for this. Bear in mind that when the guidelines were published in July 25, but practically we finished the work in 24. So the result he mentioned in Annal of Internal Medicine and Lancet 2025 were not published at that moment. Also, we had very good data on PET metomidate, but as Professor Brown clarified, this is a sort of proof of concept technique because most the 99.9% of the unit will not be able would not be able to perform this particular imaging technique. I guess that now with CETO, or even better with the AldoView, that would change completely the approach in the next, I would say, 5 to 10 years to the subtype diagnosis. And I fully agree that with this possibility, AVS would be restricted to a minority, if any, patient. So we just need to get experience with the new PET tracer, and I hope this will be diffused around the world. And I guess in the next guideline, where we will or we will consider introducing this type of PET tracer for the subtype diagnosis.
Thank you very much for clarifying. So my next question is regarding the screening recommendations in new guidelines. So you mentioned the Wilson-Younger principles, and they state that screening for a disease should only be advocated when the test to diagnose the disease is sufficiently accurate. Do you believe in a real-world setting that the aldosterone-renin ratio is reliable enough to justify that, especially with, as you mentioned, different laboratory cutoffs and variable medication use? Or do you propose that we need a stricter standardization?
This is a good question. I don't have a satisfactory answer, but I think the aldosterone-renin ratio at the moment is the best we have. Also introducing a minimum level of aldosterone that go towards increasing the specificity of the test, because the problem is, if really we believe that 100% of the patient with hypertension can be screened, we would have an overload of patients with suspect primary aldo. And so we need to be a little bit more specific, and that's why we added a minimum level of ALDO and also a level of DRC. For example, in my unit, we are a little bit less strict with raining, and we are okay if raining is even between 8 and 10, or in some cases below 15, we can consider still primary ALDO. But again, we wanted to avoid to be overloaded with patients that nobody know how to handle. Imagine the general practitioner that if they start performing the screening, they can be confused of what to do, and there's not enough endocrinologists to perform a suppression test and AVS and so on. So we thought to restrict to relatively more florid cases, and which are cases that are supposed to have a better response to anti-ALDO therapy or surgery.
Yeah, maybe I can ask you both with questions that are somehow pressuring us, because we are nephrologists, and in our ambulance we do, not by strict definitions but by gut feeling, so to say, measure for PA, and we have a prevalence with over 1,000 testings of about 26% of the patients. And our neighboring clinic, which is a cardiology with different patients, has a similar high percentage. And rate limiting now for us is what should we do with the patients when we have them, apart from applying an MRA. And we used Pentixo for this because we do not have AVS. Pentixo is not now available. Maybe both of you, what would be the ideal scenario, maybe in the forthcoming years, to have a nice flow of patients when we apply the testing, so that we have a definite diagnosis in a minimal time amount?
Our first crack at this one. So in a sense, it's much easier to look in the crystal ball than write a guideline. And that's what you're now asking us to do. And the guideline maybe came at a slightly unfortunate time, that as Paolo says, although things had been advancing over the previous decade, the advances didn't quite hit the level that a guideline committee needs to recommend them. But the fact is that we do have this new class of drugs arriving. It's important to say that, as I understand it, there's nothing that I'm aware of or published which shows the ASIs to have superior efficacy or tolerability compared to the MRAs. There's theoretical reasons why they might, and there's lots of hope. And Paolo and I might argue that some of the benefits which appear to ensue from surgery, but of course there's never been a randomized study of surgery against medicine, is because surgery and now ablation are the only methods for suppressing aldosterone rather than blocking its receptor. So I feel that because of the difficulties that we've touched on of having a robust threshold for aldosterone-renin ratio, that the purpose of making a diagnosis is to discover the minority, and I suggested in my talk it's a rather small minority, who definitely benefit substantially in long term from surgery, and that we don't need fancy tests for putting people onto a drug. And the bit of me, which is probably most of my life as a hypertension doctor rather than a primary aldo doctor, says that hypertension's got more long-term evidence, more data than almost everywhere else in medicine. And although we still argue about how to measure blood pressure, roughly a blood pressure of 140 is a blood pressure of 140. We know that people will live longer, have fewer strokes, fewer heart attacks if we treat above that. And if there's a group of patients where trials have shown that whether it's the MRAs or the ASIs do particularly well, just let's get on and do it according to the blood pressure, and keep the fancy tests and measurements for those where there's a real chance of curing their hypertension by something more interventional.
But did we not learn that the primary aldo, so to say, is not also a hypertensive disease, but the aldo itself is pro-inflammatory and detrimental for the whole cardiovascular system? And the guideline says you should aim for a restoration of physiology. So what should we aim then for apart from the blood pressure? Because I also have patients who are normotensive and have had strokes and have a PA. Should we simply look for that the renin, so to say, comes again up? Should there be certain thresholds? This is a matter of research for the forthcoming years, apart from simply giving an MRA or an aldosterone synthase inhibitor.
So my view, and it's only partly based on evidence, but I think the recent trials in what's been called uncontrolled hypertension do support this, is that rather than measuring aldosterone-renin ratio in everyone, which I just don't think is going to happen, is we do better at having a higher index of suspicion for people who would benefit from being an aldosterone-targeted therapy. So who are these patients? I think they're the patients who have not responded as well as was expected to the initial combination of drugs that are used in hypertension, so an ARB or an ACE inhibitor plus calcium blocker or diuretic. And if patients have not reached target blood pressure on those two drugs, then proceed to using an MRA or an ASI. That, I think, will become the strategy. If there are patients and I think age will be a driver here, that if the alternative to an intervention is 50, 60 years of taking a drug, I think they have a higher incentive to go through tests which might lead to them having an intervention. But I think the main driver should be failure to respond adequately to drugs. And the sort of elephant in the room, which I'm surprised Paolo didn't make more of, which is hypokalemia. I'm sort of mystified, firstly, whether it's really true, and if it is, why it's true, that with good consensus that roughly 30% of all known primary aldo has hypokalemia presentation, and you can roughly double that if you go looking for history of hypokalemia at other times. Is it really the case that the other 99% also have hypokalemia and are not being detected? So whatever the answer is to that, I would say, of course, go after the hypokalemic hypertensive and investigate, and we should be finding all those. But for the normokalemic hypertensive, I think it's the normokalemic patient not responding to conventional therapy who should then be given a trial of aldosterone-targeted therapy.
Without the aldosterone-renin ratio?
I would say, if we're talking about the whole world, and healthcare costing far more than there's money available, I would say without measuring anything. If you want to spend some more money, and it's not actually a vast amount, I would actually start with measuring renin rather than aldosterone-renin ratio. I think the ratio had its day, and the fact that the guideline stealthily dropped the threshold without even mentioning it shows how flaky that threshold is. Whereas renin, as Paolo mentioned, it's very, the levels vary 30, 40, 50% just between two measurements. Renin is more stable. I think the low renin patients, if you want to measure something and predict who will benefit, I would just measure renin.
This may be one of the final questions when it comes to the assay that is used, because there are different assays measuring renin activity versus mass spectrometry. And Paolo also showed us also the interfering drugs, which maybe is an inhibitory factor for us, so to say, going to more diagnosis, because doctors are confused what to pause and what not. And the guideline is, I think, more relaxed, just do it. What do you think about, because this is what we are doing, we use angiotensin equilibrium-based mass spectrometry. And I think we have nicely shown that in most of the publications, they are rather robust against the influences of diverse antihypertensive drugs, for example, using the angiotensin 2 aldosterone ratio, or angiotensin 1 and 2 as a measure of the plasma renin activity, because we have all these enzymes in a supersaturated manner in the serum swimming around. So, and also I think Paolo also used this kind of assay. So in an ideal world with unlimited money and work power, would it be nice to look for, 10,000 hypertensive patients? And when we find such a high number of Aldo patients with this tremendously increased cardiovascular risk for stroke and atrial fibrillation and what you name it, wouldn't it be nice to simply find those patients and immediately treat these patients?
Okay, there are several points to touch. I will start with the last one. We did a study with the equilibrium angiotensins. This is actually a very good method, but it is much more costly than just measuring with clear aldo and renin, and also it's not very easy. Not all the labs can do it. So depends if you are a referral center, if you do your activity at the top level, you have a lot of money, you can do it, but we cannot expect all Europe or all the world can measure even just aldosterone in LCMSMS is difficult for many countries. In Italy, we have only 2 centers that measure aldo in LCMSMS, and they don't do it in a routine. So at the moment, we have to stick with the most widely used technique, but I agree that other technique could be more reliable. About the cost, it is true that you add a little bit of a cost, but I have patients that come to my unit with, cholesterol, HDL, and triglyceride measured 10 times in the last 3 years. So why not one aldosterone and renin? I agree with Morris that suggested just to measure renin. If it's not suppressed, we can forget about primary aldo. The problem is that when the patient have to go in and out, that add complexity from the practical point of view. So at the end of the day, measuring the two is not too much of a difficult task. About the fact that we could just decide to give an anti-aldo therapy, there's a problem that we should stick to what is the clinical trial we have. For the moment, with the aldosterone synthase therapy, we only have a positive result in patients with uncontrolled or resistant hypertension, but uncontrolled including a diuretic. That means this patient had either undiagnosed primary aldo or, to me, secondary aldosteronism determined by that diuretic therapy. And so we don't know if the patient could benefit of the anti-aldo therapy if they're not a responder with ACE inhibitor plus CCB. Already cardiologists say that we should not give an anti-aldo therapy before the 4th class of drug because of the Pathway 2 trial, very informative, but we don't have a trial showing that MRA and aldo synthase inhibitor is not possible at the moment, really reduce the stroke, myocardial infarction, or in general the MACE. And so that's why they say we should stick to RAS blockade, CCB, and thiazide diuretic. I don't fully agree with this cardiology point, but in the era of evidence-based medicine, it is true that we never demonstrated that adding MRA as a second or third drug could reduce the cardiovascular event. So this could be questioned. And I have to say, there was a trial that was not published the ALLO trial, in which Baxdrostat was given in patients with not controlled hypertension, either just RAS blockade or RAS plus CTSB or RAS blockade plus diuretics. And in this trial, there was not a significant reduction of blood pressure level compared with placebo. It is true that there was a low adherence of the patient to the therapy. So we don't have an answer, but we don't have a strong point for suggesting to the global community that MRA or aldosterone synthase inhibitor could be given as a second or third drug, except two drugs included diuretic.
But don't you find it dangerous, like the European Society of Hypertension, just to add for resistant patients an MRA or in the future an RC, not knowing that you maybe have to treat a primary Aldo patient who maybe needs 50, 75, 150 spironolactone, just that the renin is again desuppressed, so to say. Because we treat patients not knowing then what the molecular problem is there. We'll only look at the blood pressure maybe, but the renin is maybe still suppressed. I have many patients that need maybe 150 spironolactone. Yeah.
150 of spironolactone, you have 60% of patients with gynecomastia and probably dysfunction.
I know the complaints, yeah, but the fact is that we do not know what molecular goes on there if we just treat them without knowing the renins. Yeah.
Yeah, but
I mean, I can say in the UK, I think the Americans have more of a problem because beta blockade is still widely used in the States, and beta blockers are the big confounder of renin measurements, as you saw in my first slide. In the UK, beta blockade dropped out of use, more or less, with the NICE guideline in 2006. And so when we recruited for Pathway 2, the background treatment with no difficulty in all patients was A plus C plus D. And we could look at B as a fourth-line agent. And in my clinic, when I don't do a routine hypertension clinic now, but when I did, most reasons for referral was patients not at target on 2 or 3 or sometimes 4, 5, 6 drugs. And I would always measure a renin. And it's not that expensive. And with the advent of the renin mass assay, it's just as easy to do as Paolo says, as measuring LDL or HDL. The question is, can you extrapolate from what we do in the specialist clinic to recommending that everyone does it? I think by the time someone's referred to a hospital, I would say undoubtedly you want some measurements. I'm just less sure about saying that every primary care doctor should be doing these measurements. And I mean, just to tell you an anecdote about the problems of interpreting the ARR ratio, the WAVE trial that we're doing, we have 6 centers. And because the guideline recommends that you should be doing a confirmatory test in people who have surgery and don't come down to target ARR, we were trying to work out after the new guideline what the new AR was and all the permutations of measurements being used in the different hospitals, mass spec, non-mass spec, renin mass, renin activity. And even for us as specialists, it took us 2 hours at least going through it with a slide rule, working out what thresholds we should be giving to each of our centers, that we should be calling people back. You know, if it takes us 2 hours as specialists working out what the thresholds are, how is it conceivable for every, because most hypertension gets nowhere near a hospital, how is it conceivable for every patient with primary aldo to have, every patient with hypertension, to have an AR measured and interpreted by their primary care doctor?
Of course. So final question, are you and Paolo aligned, because this is a main message of this episode, that the real number of patients that will need surgery is in the low single digits percentage?
You mean percentage of hypertension or percentage of primary aldo?
Primary aldos.
You go first, Paolo. You started.
It's difficult because depends on what you consider primary aldo. If we say primary aldo as we diagnosed traditionally until a few years ago, uh, uh, depends on how much is a specialized the center, because there are centers that receive patient just for very, very suspicious unilateral PA to perform AVS. And in this center, maybe it's 50% of the patient that need surgery. In my unit, we receive patients maybe a little bit less selected, so we are around 30%. But if you are, let's say, a cardiologist or a general practitioner, and you screen everybody, I'm sure the number of patients requiring surgery is less than 10%. And we don't know how much less than 10%, because we tend to call primary aldo patient with a more florid phenotype. If we believe the data of Anand Vaidya saying that even normal people have a primary aldo in 11% of the cases, which to me is difficult to accept. But if we consider very permissive cutoff, and in these cases, that would reduce the percentage of surgically treatable patient to less than 3%, I would say. But I don't know, Maurice, what do you think?
My answer is I like to recall that at the start of my medical career, there's another roughly 1 centimeter benign lesion which starts with a P, peptic ulcer, PU. And at the start of my medical career, people were still taking out a whole organ as treatment for this 1 centimeter benign lesion. And then briefly, I remember holding the retractor surgery for vagotomy and pyloroplasty, which I think is akin to our advent of ablation. And then the H2 antagonists, and of course, omeprazole appeared. And now peptic ulcer is cured by a week of treatment with a well-tolerated drug. And I believe that the use of surgery and taking out a whole organ for small benign lesions is of a level with what was happening for peptic ulcer at the start of my career. My hope is, as I've said, that the ASIs may turn out to be the omeprazole of primary aldosteronism, and that if this phenomenon of the long-term suppression of aldosterone after a few months of dosing is real, then the debate we're having now will pass into the history books. But meanwhile, I still think that we need to be much more selective about finding the patients who will be completely cured by surgery, and that the numbers, yes, will be in the low percents of those referred and very low percents of all those who have the condition.
And so ultimate final question, so you think the 18-hydroxycortisone would be maybe then a more broadly applied marker for those patients?
That's how it's looking, and because we know for certain it requires both enzymes, what we call CYP11B1 and B2, the beta-hydroxylase and the aldosterone to be in the same cell. And that, again, molecular science was what proved that, because the first monogenic cause of hypertension was the so-called glucocorticoid-remediable aldosteronism, where you actually have a chimera of the two genes, and they have very high levels of a hybrid steroid in their urine. I showed you our data. We're not unique. Other centers have been measuring hybrid steroids. Like with everything, there'll be the odd exception, but it looks to be a good predictor of the case in J5s. And I think I will be happy if we replicate that finding in our current study, in saying that we shouldn't be sending someone to surgery unless they've got the phenotype of a case in J5 with a high hybrid steroid.
Super.
If you allow, we would have two very final questions, actually. The one is of clinical importance, I guess, and goes to Paolo. So in your guidelines, you actually recommend to do dexamethasone testing in all people with adenomas and we just saw the ACC, the momentum study, which suggests that autonomous cortisol secretion is quite high. So can one do the test in one go? So can one go for dexamethasone in the evening and the next morning test cortisol, renin, and aldosterone, or would you have to go for 2 different days, which would make it more difficult? And then my very last question goes to Morris. So your data are fascinating on the idea that the ASIs may be cytotoxic to adrenal cells. Will this only apply to those cells who are overproducing aldosterone, or might there be a risk of kind of harming normal adrenal glands in people who receive ASIs for essential hypertension?
Okay, dexamethasone suppression test, but you have to do it in a different day compared of the measurement of aldosterone renin. But it never happened that you need to do both in the same day, because first you have the aldosterone renin ratio that is high, and then eventually, if you go further, you find a nodule before AVS, you want to do the dex suppression test. And so you don't need to measure aldosterone renin anymore at that point. And if you are doing a large screening of secondary hypertension, so you include Cushing, primary aldo, and so on, the dex suppression test should be done in a different day, but it's 2 different situations.
Gunnar, an amazingly good question. The first thing to say is, and comes back to the previous one, is that if most primary aldosteronism does not turn out to be truly unilateral, and there's probably more consensus for that than most of the things that I've been saying, then you would actually expect a drug to be more effective than a unilateral intervention. And it's sort of surprising that generally spironolactone doesn't turn out to be as good as surgery, and that's probably telling us how dose limited we are in how much spironolactone we can give to patients. So the other side of that coin is actually a safety risk about taking away all the aldosterone synthase from both adrenals. And there has been a hint of that with anecdotal reports with osilodrostat, that patients who have their cortisol synthesis wiped out, some of them need replacement therapy, and there's even a report of shrinking adrenals on that drug. And it would definitely be important to address that. And there is a phase 3 trial now with baxdrostat in PA, and we should get data from that. I would probably say that would be a nice problem to have, if you know what I mean. It would be so exciting to show that we can actually cure the disease, that if it turns out we really wipe out the aldosterone synthase, we'll have to learn how to monitor the dose, give less of it, etc. And your final question, or it was actually your first, about does it only work when there's an abnormal level of aldosterone, gets to the heart of what I think the drug may be doing. And although the mouse models are very clear about the final result, that the cells disappear, they don't say anything about mechanism. And in the New England paper last year for SPARK, I've speculated in a long legend to a schema that I'm sure no one's looked at about what the mechanism might be. And I think it might be to do with the fact that aldosterone synthase uses a lot of molecular oxygen, 3 molecules of oxygen for every molecule of aldosterone that's made. And if you inhibit that, whether it's by taking the gene away, by suppressing it with dietary salt, or by giving an enzyme, you set up an imbalanced reaction with lots of free oxygen radicals being generated. And my guess is those free oxygen radicals which damage the cell and make it disappear. So I suspect there's more scope for that to happen if there was a lot of aldosterone being made in the first place. But I doubt it's completely selective for abnormal aldosterone. And as both of us have been saying for the last hour and a half, what do you call abnormal aldosterone? There's no hard and fast line which you can draw that.
So many thanks to both of you for the incredible presentations and the great discussion. We could have continued talking about hyperaldosteronism for hours, and we hope to have the opportunity to welcome you back again someday. So thank you for your time and for your talk, and we hope to see you again and welcome you back by Marcus at Home.
For inviting us.